Hey guys, can you hear me? Am I audible, visible? If so, say me a hi and a hello. Uh,
Let me circle it. I couldn't find anything, let me circle it. So let me circle it.
hey guys, can you see me and can you hear me? If so, say me a hi and a hello. Hope I'm audible and visible. Yes. So, good afternoon, everyone. And how many of you are preparing for your NEET PG exams? Good afternoon, Nidhi. Hello, Dr. Basila. Good afternoon. Okay. So this is a quick recall of image-based questions primarily targeted for FMGE aspirants. Definitely be useful for the NEET PG exams as well. Fine. And I hope that today your NEET PG will be announced when the NEET PG exam happens. And I hope NBV will not fail us once again. For the NEET PG. Fine. Okay. So with that note, I'm going to discuss a series of questions. I want you guys to be interactive as much as possible. And not just the answers, we'll also slightly see some information about the other options so that we can cover the particular topic and also a few more images if required, right? So let's start. I want you guys to answer the question. Fastest finger first. So let's go with the first question. Comment A, B, C or D, right? That doesn't make much of your effort or energy. I'll read the question for you guys. Elderly man in the 50s complains of darkened skin, avoiding sun exposure. Physics examination. Hello, your drug of choice. Hepatomegaly was found. Liver microscopy is seen in the slide below. This is a liver microscopy. Can anyone tell me what stain is this? Because that will easily answer my question. Nidhi has gone with option C. Anyone else? So I'll give you a clue. This stain is your Pearl's Prussian blue. Fine. There's a Pearl's Prussian blue stain. So that's a clue here. Now tell me what could be the appropriate diagnosis. A, B, C or D? Okay. Dr. Basila again, C. Answer is obviously A, right? If it's Pearl's Prussian blue, it's a stain for iron pigment. Obviously, it's a patient with hemochromatosis with the involvement of the liver, right? So that's the appropriate answer. Just few informations regarding the other options, like I said, right? So Wilson is accumulation due to copper, right? So can anyone tell me the stain useful for copper? It's completely fine, Nidhi. It's okay to make mistakes here. Don't make mistakes in the exam. Copper has rhodamine. Copper has rhodamine or rhodonite. Copper has one more stain called as rubionic acid. That's other stain for copper. And copper is a very useful stain called as orcine, right? So these are three stains useful for copper. Same history can also be a case of Wilson's disease. If it's a rubionic acid stain or an rhodamine stain or an orcine stain, you think of an copper accumulation in Wilson's disease, right? So can anyone tell me what will be the microscopic finding, right? I'm specifying microscopic finding for alpha-1 antitrypsin deficiency. That's a very classical one, right? You see PAS positive, diastase resistant or sensitive? That's a catch there. It's PAS positive, diastase resistant granules, right? Because your protein, it will be diastase resistant globules if they are there. That's a classical finding in case of a liver biopsy, in case of an alpha-1 antitrypsin deficiency, right? And autoimmune hepatitis, primarily they don't have any microscopic staining pattern, but if you look at the question, interface hepatitis, these are the keywords. In a young woman, think of an autoimmune hepatitis and also the viral serology being negative. If the viral serology is negative, interface hepatitis and also seen in young women, think of an autoimmune hepatitis. Fine, great, perfect. Right, these are few points regarding the other options. The same thing what we're going to do in the next every question what we're going to discuss today. Right answer and few points in and around the wrong answers. Fine. Okay, go ahead. Answer. It's a very simple one. Biopsy from a midline swelling in the neck revealed orphan Annie eye nuclei, right? Even if the question orphan Annie eye nuclei is not there, you should know the answer. This is how an orphan Annie eye nuclei looks. All these are clear cytoplasm, right? So when you have a clear nuclear, extremely washed out nuclear membrane, that's an orphan Annie eye nuclei seen in case of papillary carcinoma thyroid, right? Just few more questions related to the other options as well as papillary carcinoma thyroid. Can anyone tell me what mutation comes to your mind when you think of papillary carcinoma thyroid? Papillary carcinoma has one classical mutation because genetics in thyroid is becoming a little bit more important these days compared to older ones. One is BRAF. BRAF mutation is positive in case of papillary carcinoma thyroid, and RET induced translocations. Not RET mutation, it's RET translocations, right? So these are common in case of papillary carcinoma thyroid. If there's any advanced question or a new question, this might be which will come handy for sure, right? To call something as in follicular carcinoma thyroid, perfect, Nidhi. To call something as follicular carcinoma thyroid, what is the finding required in microscopy? RET is a proto-oncogene, Samantha, so that will get translocated, fine. So to have that, you need undoubtedly your capsular or a vascular invasion, right? So one more question related to follicular carcinoma thyroid. Can we pick up follicular carcinoma thyroid on an FNAC? Can you diagnose or not? Fastest finger first. Yes, no. Follicular carcinoma thyroid cannot be diagnosed on an FNAC. That's an important question. You can't diagnose them on an FNAC. You need a histopathological sample or a post-surgical sample, right? You cannot diagnose. That's one of the contraindications. Biopsy is not done in case of follicular carcinoma. No, biopsy is required because FNAC cannot diagnose follicular carcinoma thyroid, right? That's about it. So medullary carcinoma thyroid, what is the important finding? This came in your recent INICT as well. If this finding is there in thyroid, I think of medullary carcinoma thyroid. What is that? What's a microscopic finding? You have amyloid. If you see amyloid in microscopy, that's diagnostic of medullary carcinoma thyroid. Again, one more leading question. Can anyone tell me what is the tumor marker or an immunohistochemistry for medullary carcinoma thyroid? Perfect, KK. Tumor marker or IHC? That's your same thing what your parafollicular C cell secretes. That's your calcitonin, right? So calcitonin is a tumor marker as well as the immunohistochemistry for medullary carcinoma thyroid, right? So medullary carcinoma thyroid, again a fastest finger first. You see them in MEN1 syndrome or MEN2 syndrome. Where do you commonly see medullary carcinoma thyroid? ACAL is the amyloid and yes, calcitonin is the IHC. You see medullary carcinoma thyroid commonly in MEN2 syndrome, right? Both 2A and 2B, or the recent one is MEN2 and MEN3. You see them in MEN2, not in MEN1, right? MEN1 is the parathyroid, pituitary and pancreatic lesions. MEN2A is where you see them. Perfect, guys. Okay. Next question. This is an old NEET-PG question. It's just for the translocation, right? What's your answer? This is not a very commonly seen thing in a routine diagnostic center or even for undergraduate. If you have a question says translocation 1216, that's diagnostic of an myxoid liposarcoma. Remember that, that's more than enough, right? If the same question repeats, I want you to know the answer. That's more than enough. If you have any question of a soft tissue lesion talking about translocation 1122, which soft tissue lesion will have translocation of 11 and 22? Which soft tissue lesion will have translocation 11 and 22? This will be seen in Ewing sarcoma, right? So this is a very common translocation which has come. Translocation involving X chromosome and 18th chromosome or any partner chromosome. Most likely translocation involving the X chromosome. Where do you see X18? No, mantle is different. Mantle is 11, 14, right? I'm talking about soft tissue lesion. X18 is for your synovial sarcoma. Okay, that's important. These are few soft tissue molecular genetics is required because it's been routinely used these days, right? Just one add-on question finding here. If you see any question which is coming in future with term polymorphic lipoma, you have a named cell correlation, floret cells. Floret cells are the microscopic finding in case of a polymorphic lipoma. That's diagnostic of a polymorphic lipoma. You might not have, if there's any INICT exam which wants to ask a higher level of questions, they might ask this, right? Perfect. Next question, a very simple one. Read the question, look at the image and comment on the answer. Everyone here online, I want you guys to comment. It's okay if you make an error or a mistake. I'll read through the question. 6-year-old, right? That's the clue here, right? I will stop the question with this. A 6-year-old, which is common. Just tell me that. I don't want anything else. In a 6-year-old, which you think is common? Dr. Phobia, Dr. Bezilla, Ashish, 6-year-old. There's only one thing which can be common as a 6-year-old, right? That is juvenile, right? So see, that's the importance of a scenario-based question. Every point might be the clue. Microscopy is a bit difficult for a colonic polyp, but I'll tell you how to easily identify them. Obviously, 6-year-old juvenile polyp. Rectum, that's the most common site of juvenile polyp in the rectal region. Seen in children, Rectum is the most common thing. Juvenile polyp is a type of a retention polyp. So since it's a type of retention polyp, what I see in microscopy is mucus containing glands or mucus retention, right? That's why we call it a retention polyp. You see multiple tiny cyst-like spaces, empty spaces. That's nothing but mucus retention seen in the polyp, right? There are 4 GA polyps which can be asked: villus, tubular, Peutz-Jeghers, juvenile. The 4 options. The clue for juvenile is the age. Please remember, none of the other polyps happens in a child. Very rarely happens in a child. Almost impossible, let's assume, right? Okay. SMAC4 can be seen. See, in a juvenile polyposis syndrome, whatever Nidhi you said, you can see them. In a sporadic juvenile polyp, I might not see them. Fine. Okay. Now, tell me what tumor is this? Same 4 options: tubular, villus, Peutz-Jeghers, juvenile. The way to identify juvenile, like I said, cyst-like spaces filled with mucin, and these are your villi. Perfect. So these are your villi. So when I have villi more than 75% of the biopsy, I call it a villus adenoma, right? Okay. Can you rephrase it, Samantha? This is for an upcoming exam aspirant, so I'll not be going with the Robbins read with me here. Fine. Okay. Next here, if you look at this polyp, this is actually the normal intestine. You can see that's projecting from the normal intestine. We call it a polyp. When you see tiny glands in a polyp, the tiny glands are nothing but tubules, and we call it a tubular adenoma. Can anyone tell me what is the diagnostic criteria for a tubular adenoma? What's the percentage of villi should be seen in case of a tubular adenoma? That's a very common one which has been asked. Percentage of villi? Villi should be less than 25%. Only when villi is less than 25%, we can call it a tubular adenoma. Always is based on the villus architecture, right? One more leading question. This might be important for surgical point of view as well. Of these 2 tumors, villus adenoma, tubular adenoma, which will recur frequently, which has more risk of malignancy, tubular or villus? Which will recur frequently, more risk of malignancies? Sure, Samantha, look into it. Obviously, villus adenoma will recur frequently, and there'll be more risk of malignant transformation. Tubular adenoma is very subtle. Tubular is very subtle. Villus has more risk of malignancy, and villus has more risk of recurrence. Please remember the miraculous as well as Nidhi. Okay, tubular is subtle lesion. Fine. Okay, perfect. Next one. So this tumor, if you look at this tumor, you see muscle which is going into the tumor, right? Kind of like looking like a tree. What's a tumor? Microscopically, if you see muscle between glands, you call the tumor a Peutz-Jeghers polyp, right? Peutz-Jeghers polyp or a Peutz-Jeghers in syndrome also I'll see the same polyp, right? Few leading questions regarding Peutz-Jeghers polyp. What's the most common site of Peutz-Jeghers polyp? Can anyone tell that? Most common site of Peutz-Jeghers polyp? It can most commonly arise in jejunum. Okay. In patients with Peutz-Jeghers syndrome, not the polyp, right? In case in patients with Peutz-Jeghers syndrome, tell me what is the other finding apart from the polyp? Do you know any other finding apart from the polyp in Peutz-Jeghers syndrome with respect to oral cavity? You'll have oral mucocutaneous hyperpigmentation. Okay, that's very classical for Peutz-Jeghers syndrome. Again, one older question which came in NEET exam: which organ has the maximum risk of having cancer in case of a Peutz-Jeghers syndrome? Not the polyp, Peutz-Jeghers syndrome. Which will have maximum risk of malignancy? The maximum risk of malignancy is not in the intestine, it will be pancreas. You will have pancreatic cancer, breast cancer, GI cancer everywhere, but pancreas has the maximum risk of malignancy. All others will also have, but pancreas is very high risk of malignancy in case of Peutz-Jeghers syndrome, right? 4 polyps, you have muscle between the glands, Peutz-Jeghers, villi, villus adenoma, tiny glands, tubules, tubular adenoma, and you have a cystically dilated glands with mucus like this. It's a juvenile polyp or a retention polyp, right? Next question. Come on to the answer. It's a simple one. What comes to your mind? Okay, the lining epithelium of a respiratory tract of a chronic smoker shows a change from columnar to stratified squamous epithelium as seen in the image. That's a classical example for metaplasia, right? Few leading questions regarding all the options here: dysplasia, metaplasia, hypertrophy, and atrophy. Okay, metaplasia, reversible or irreversible? This obviously is your ciliated columnar, and this obviously is your multi-layered squamous epithelium, right? Metaplasia, reversible or irreversible? Metaplasia is undoubtedly reversible, right? Dysplasia, I'm going to divide dysplasia into 2 things: Low grade and high grade dysplasia. Low grade dysplasia, reversible, irreversible. Low grade dysplasia. Low grade dysplasia is still reversible, right? When it's only high grade dysplasia, it becomes irreversible. Or your CAN1 in cervix is reversible. 2 and 3 is irreversible, right? That's why we go for a surgical management of 2 and 3 and medical management for CAN1, right? Okay, next question. The most common cause of metaplasia, is it Barrett's esophagus or smoking? Most common cause of metaplasia, undoubtedly it is smoking induced, right? Because smoking is definitely more common than GERD. So definitely smoking is the most common cause of metaplasia, right? Can anyone tell me one example for an mesenchymal metaplasia? So in mesenchymal metaplasia can also happen, though epithelial is way common than mesenchymal. Any one example for mesenchymal metaplasia? Perfect. We have something called an myositis ossificans, right? Myositis ossificans, where you have bone formation in the muscle. That's a classical example for a mesenchymal metaplasia, right? Last question regarding metaplasia. A patient with an vitamin A deficiency causes metaplasia, or a vitamin A excess causes metaplasia. What is that? Or is it both? Vitamin A deficiency or vitamin A excess? It is both. Vitamin A alone is very, very specific. Both deficiency and excess can cause metaplasia. One of the classical example, your Bitot spots in your eye, right? Bitot spots in eye is actually a patient, nothing but a metaplastic change, that's all. If the keratinization happens in the squamous epithelium here, it's Bitot spots, right? Xerophthalmia is same. Both excess as well as deficiency of vitamin A can cause metaplasia. Do remember this, right? Perfect. Next question. Come on to the answer. Great. Read the question carefully and tell the answer. 15-year-old has been coughing for 15 days. Cervical lymphadenopathy was noted and the lymph node biopsy is shown below. I'll zoom the biopsy if you guys want. This is a biopsy. I hope you can see this structure. That's a clue here. I circled it. Let's go back. Diagnosis, TB, right? If you make a mistake on tuberculosis and granuloma, God will definitely come and prick your eyes in your exam, right? Cough, any time, any age group, cough, expectoration, lymph node or chest lesion has to be one and only tuberculosis, right? Rest everything is ruling out. Leprosy, very, very unlikely to form a cervical lymphadenopathy and a cough. If the same image is given and you have a patient with skin lesion, yes, I might think of a leprosy. I won't think of a leprosy here because clinical feature is not fitting into it. Again, syphilis is not fitting into it. And by the way, syphilis will not cause granuloma. Syphilis, classical microscopic finding is they will cause obliterative end arthritis. This is a classical finding in case of syphilis. You can relate this with every symptom of syphilis, right? What's the symptom of primary syphilis? Can anyone tell me what's the first finding you see in a syphilitic patient? You'll see ulcers in the external genitalia, obliterative end arthritis. If the end artery is obliterated, will there be an ulcer formation? Skin necrosis and ulcer formation, right? That's what syphilis causes, an obliterative end arthritis, that's all, right? And the circle, what I did was your Langhans type of a giant cell, right? Perfect, okay? Sarcoidosis is always a diagnosis of exclusion. Please don't jump into sarcoidosis unless and until you see all the classical findings of sarcoid. Always the last, right? There are few words which I want to add in sarcoid. Sarcoid will cause necrotizing or non-necrotizing granuloma? Definitely non-necrotizing granuloma, right? Sarcoid should have non-necrotizing granuloma. Sarcoid should have an X-ray involvement finding for sure. Sarcoid should have increase in the calcium levels because the giant cells in sarcoid will cause more PTH-like peptide, which will cause hypercalcemia. And sarcoid should have increase in the ACE levels. Angiotensin converting enzyme. If you have all these findings, then even then I need to rule out tuberculosis. Maybe if the same history is given and the patient is acid phosphorylated negative or a RT-PCR negative, I might think of sarcoid. Otherwise, don't think of a sarcoid at all at any point of time. Fine. Next question. Options. Look at the image. Comment on the right answer. Carpal tunnel, I think you mentioned Crohn's, autocorrect, right? Yes. A middle-aged woman with long-standing history of dyspnea, chronic cough with sputum, wheezing, brought to the hospital, died. Person is not a smoker or an alcoholic. This is a lung at autopsy. You can see the lung, most likely diagnosis. Amazing, right? It's classical alpha-1 antitrypsin deficiency, right? This is nothing but a classical history of an emphysema. Here, what is striking here is the patient is not a smoker or an alcoholic. So, in spite of that, lung is getting damaged or the alveoli is getting damaged, right? There are only two types of emphysema. These two are the images from Robbins, right? One is pan-SNR, one is centri-SNR, right? I'll mark them as 1 and 2. You tell me which is centri-SNR, 1 or 2. Both are gross images. Sorry, I think I have put both the same image. Ignore that. It's an error from my side. Both of these are nothing but centri-SNR emphysema, right? My mistake, my bad. Ignore this, right? If you see this image, actually you can see emphysematically dilated alveoli. At the same time, you can see normal alveoli, right? When you see both normal alveoli and emphysematically dilated alveoli, that's your centri-SNR emphysema. Your drug of choice, yes, like I said, it's my mistake. Sometime maybe exam also will have mistakes like this. Don't think that they are super intelligent. Everyone makes mistakes. That's it. Fine. Okay. But both alveoli and normal space, I call it centri-SNR. At the same time, if you look at this image, do you see normal alveoli? Do you see any normal alveoli? No, it's completely dilated, right? If only dilated alveoli is seen, that's pan-SNR. If you see both normal and dilated alveoli, that's your centri-SNR emphysema. Okay, great, perfect. Just one more leading question. History of smoking. If history of smoking is there, is it always centri-SNR or it can happen in pan-SNR also? Let's say a patient is with alpha-1 antitrypsin deficiency, smokes. Will the patient still have emphysema? Will still have lymphoma, right? So this is a very, not an absolute finding, it's a relative finding, right? Why I'm saying is, I'm just going to rephrase the same question. Let's say this patient is a smoker for 10 years. Will the answer change to centri-SNR? The patient is a smoker for 10 years, died, has the same finding. Will the answer change to centri-SNR or still it's pan-SNR? It's still a pan-SNR emphysema. It will not change, right? Okay, Samantha, if you see both normal and dilated alveoli, it's centri-SNR emphysema. If you see only dilated alveoli, it's a pan-SNR emphysema. Fine. Okay, perfect. Okay, next question. Answer. First, tell me what's the diagnosis. Then let's go to the pedigree charts. Diagnosis. 196 centimeter tall person found to have an early diastolic murmur. Pedigree chart is shown below. You guys, I want the diagnosis first. Then let's go to the pedigree chart. Marfan's, right? So this might fit into Marfan syndrome. If it's Marfan syndrome, I go for an autosomal dominant inheritance by default, right? HOCM very, very unlikely carpal tunnel here because early diastolic murmur could be due to anything, right? HOCM will have mostly sudden cardiac death. That's how it will happen. That's the height of 196. And cardiac pathology fits into a Marfan syndrome. Marfan syndrome is autosomal dominant, right? At the same time, we can solve it via this pedigree also. It's very simple. There are only 3 rules of pedigree. First rule, any pedigree given to you, rule out it's mitochondrial or not. That's the first rule. When will you think of mitochondrial? When mom is affected, how many kids should be affected for mitochondrial? It should be 100%, every kid, right? Perfect. If dad is affected, how many kids should be affected? If dad is affected, none of the kids should be affected, right? That's the first thing you have to rule out. Obviously, this pedigree is not mitochondrial. That's the first thing, right? Then it's very simple. These 2 flowcharts, the PDF will be there in the Telegram group. Please download, have a screenshot of this. These 2 flowcharts are enough to diagnose any pedigree. All generation affected. If the answer to this is no, I think of a recessive disorder. Only men affected, I think of an X-linked recessive. Both men and women affected or both the genders affected, I think of an autosomal recessive disorder, right? All generations means every generation at least one person affected, right? Second part, if every generation affected, answer is yes, it's a dominant disorder, right? If it's a dominant disorder, first question I ask is there a dad to son transmission, right? Let's keep a very simple example. Let's assume I have an X-linked dominant disorder. If I have to give birth to a son, what chromosome should I give so that the fetus can become a son? Y chromosome? Yes, otherwise the fetus will become a daughter, right? So is there any chance as a father I can transmit my disease, X-linked dominant disease to my son? I cannot. There's no possibility I can transmit my X-linked dominant to my son Because I need to give Y chromosome to form a son, right? So if there is a dad to son transmission, if there is, answer is undoubtedly autosomal dominant, right? If there is no dad to son transmission, I think of an X-linked dominant. Then I ask one more question. If the dad is affected, if all daughters are affected, answer goes back to autosomal dominant. As simple as that, right? This is the dominant flow chart. This is enough for us to take care of the entire pedigree. We'll look at the pedigree once again and see if it fits here. That's it. Fine. Okay, let's look at the pedigree. Can I say in this all generations are affected? Yes, no. All generation affected? Absolutely yes. Right? Is there a dad to son transmission? Is there a dad to son transmission? Yes. So it has to be autosomal dominant. That's all. If there is a dad to son transmission, by default, it becomes an autosomal dominant inheritance. I need not have anything else. Only when this no, I have other problem. Fine. All generation affected, dad to son transmission present, it has to be an autosomal dominant inheritance, right? With this flow chart, let's solve few more pedigrees. All generation affected or not? Definitely no. Don't forget this, it's not affected, right? If all generation not affected, I think of a recessive disorder. Only men affected, both men and women. Both men and women, right? So it is autosomal recessive disorder. As simple as that, right? It's autosomal recessive. It'll take less than 10 seconds for you to solve a pedigree. Fine. Next, all generation affected or not? Answers again, no, right? If it's no, I think of recessive. Only men, both men and women. I always love this pedigree, right? We'll think of a both men and women and we'll jump into autosomal recessive by default. So when we make that mistake, that's when we should remember I should not skip rules. What's the first rule? Perfect. The first rule is always mitochondrial. Please rule them out. If you don't rule them out, you will end up in a mistake, right? First, any pedigree given to you, think mitochondrial or not. Mom affected, all kids affected, mitochondrial. Dad affected, none of them affected. Mom affected, all kids affected, right? The reason why this is important is mitochondrial is a non-Mendelian inheritance and the flow charts are for Mendel's law of inheritance. That's why it's important. The first thing, think it's mitochondrial. If it's ruled out, use the flow chart. That's more than enough, right? All generation affected or not? Definitely it's not mitochondrial, 100%, right? All generation not affected. It is by default a recessive disorder. If it's a recessive disorder, only men affected here. So it's an X-linked recessive disorder. Clear? That's very simple, right? So before the day of the exam, remember these two flow charts. If it comes in the exam, vomit and come outside. Because it's just for 1 mark, that's all. In your life, you're not going to ever read autosomal dominant or recessive pedigree. Hopefully not in future, fine? This is X-linked recessive, Samantha, fine? Okay, next question. Diagnosis. I really don't know why people still keep asking this question. Even in INICT, they ask this question. It's sometimes very difficult to see this question, right? At some point of time, we have to move out of rheumatic fever, rheumatic heart disease, and ash of body disease. I can't go to rheumatic heart fever because that still exists in the world and in our country, but ash of body should go away, right? This collection of cells cause an ash of body, okay? And ash of body is a spotter for your second year MBBS and it keeps on continuing forever in your life, right? Just only one question related to ash of body. What's a type of necrosis you see in ash of body? As a classical rheumatic heart disease, what type of necrosis do you see in ash of body? It is fibrinoid necrosis, right? Because heart and blood vessels, in both the type of necrosis is going to be fibrinoid necrosis. Heart is the nothing but a largest vessel. Everywhere you'll see fibrinoid necrosis, right? You won't see any other necrosis. Fibrinoid necrosis, collection of macrophages, nothing but an ash of body, right? Perfect. Okay, next question. Read this question, tell me the answer. Maybe the image is very small. Read the question first and then I'll zoom it up. 65-year-old, anemia and hemoglobinuria. Investigations revealed an increased lactate dehydrogenase and the peripheral smear is like this. This is a peripheral smear finding. I'll highlight for you a few important images here where all I want you to concentrate. So these are the places which I want you to concentrate. Diagnosis. Tell me what cells are these first. Then let's go to the diagnosis. What cells are these first? These are, can I call them classical histiocytes, broken RBCs? right? These are broken RBCs or these are histiocytes. They're not burst cells because burst cell will be very uniform. Here it's very irregular, right? If so, this is nothing but a histiocyte. Fine. If these are histiocytes and there's a history of hemolysis, hemoglobinuria, elevated LDH, right? So if there's a histiocyte, what's the only history which will fit into histiocytosis? Splenomegaly, unlikely. Can I say this will fit inside? Because the patient will have metallic heart valve, right? Can I say metallic heart valve can cause fragmentation syndrome? Yes, they will cause fragmentation syndrome. Metallic heart sound is one thing which can fit into this patient diagnosis. This is a bit of an indirect question which came in INICT, but this is a very beautiful question, right? You have to identify what it is, then relate accordingly. Fine. Frontal pausing, I would see in patients with an thalassemia or maximum any other congenital severe hemolytic anemia. Splenomegaly, you will see in extravascular hemolysis or intravascular hemolysis. Let's devise the concepts of hemolytic anemias. Splenomegaly, extravascular, right? This patient has hemoglobinuria, intravascular or extravascular? Where is the lysis? There is intravascular lysis here, right? Generally, you see splenomegaly in extravascular hemolysis. In this patient, histiocytic anemia, it is intravascular hemolysis in this patient, right? And goiter has nothing to do with this, right? Goiter has nothing to do with this patient, so ignore that part. Fine. Okay. I'm just going to think out loud here. Let's see how many of you guys can answer. If a patient has a goiter and I'm going to have an RBC problem, right? What type of RBC problem you can expect in a patient with a goiter? Randomly thinking out loud. Because hemoglobinuria is seen in intravascular hemolysis only, Samantha. Patients with thyroid problem can have macrocytosis. Okay, because hypothyroidism is one of the important cause of macrocytic anemia. Autoimmune hemolytic anemia, yes, I can expect a little bit with linking with Hashimoto's thyroiditis, but generally patients with hypothyroidism will have a macrocytic anemia. Do remember that. Fine. Few more questions, few more spotters in RBC disorders. Diagnosis, that's classical, right? Hypersegmented neutrophils. Hypersegmented neutrophils diagnosed with megaloblastic anemia, right? Diagnosis, spotters. These are spotters. This is a very, very tiny RBC, right? So I think of an microcytic hypochromic anemia. Most likely diagnosed, I think of an B12 deficiency, right? You think of a B12 deficiency, something of that sort. Fine. Perfect. Second is spotter. Diagnosis, irregular projections in the RBC's blunt projection. This is nothing but an acanthocyte. Acanthocyte is seen in liver failure and also a famous A beta lipoproteinemia. You will see them, right? Perfect. That's an acanthocyte, or the other name is spur cell, right? Spur is the other name for acanthocyte. Burr is different. Fine. Perfect. Spotter. Diagnosis. And what's the first disease you will think of when you see this cell? When you see these cells, you think of an target cell, right? Target cell is the first thing, and obviously the first diagnosis I want you to think of is thalassemia. But though you can see them in sickle cell anemia and severe case of IDA, but the first thing has to be in thalassemia, right? Perfect. Spotter. Diagnosis. These ones. This, maybe to some extent this. That's a classical case of a sickle cell, right? That's a classical sickle cell anemia or an drepanocytes, right? Perfect. Great. Again, it's an inclusion body. What is this inclusion body? It's a Leishman stain where you have multiple irregular inclusion, right? That's your Pappenheimer body. Where do you see Pappenheimer body? You see them in sideroblastic anemia, right? This is not a basophilic stippling. Basophilic stippling will be completely uniform. Here is irregular, right? Irregular, non-uniform inclusions of Pappenheimer bodies seen in case of a sideroblastic anemia, right? Perfect. Okay. Next one. This is spotter. First of all, this stain is new methylene blue stain, and I have a tiny dot here. I'll give you one more clue if you guys want. This patient had hemolysis after taking primaquine. Diagnosis. What's the structure called and what's the diagnosis? History of hemolysis after primaquine. That's your classical grade phobia. That's your Heinz body, right? See, Howell-Jolly body is seen in case of an Leishman stain Heinz body is seen in case of a new methylene blue stain, right? Both look the same, right? This is how a 𝐒𝐻𝐿 body looks. See, look at the difference. 𝐒𝐻𝐿 body is seen in a Leishman stain. Heinz body is seen in a new methylene blue stain, right? This is a 𝐒𝐻𝐿 body. Your splenectomy, asplenia, everything fits into this. And this is your Heinz body, which you see in G6PD deficiency, right? For all inclusions, please first see what stain it is, because that's what determines everything. Because every inclusion looks like a dot or multiple dots, fine? Okay, next question. Let's see how many of you can crack this. There was a recent question, INACD has a question similar to this. Multiple yellow plaques in the trigone of the bladder, and this is an histopathological image. I'm sure you must have memorized this question, right? So you must have memorized this question. These are your calcification seen in macrophage. That's nothing but a 𝐒𝐿𝐿, right? 𝐒𝐿𝐿. Tell me, what will be the microscopic finding of a drug-induced interstitial nephritis? 𝐒𝐿𝐿 body, it's perfect. In case of a drug-induced interstitial nephritis, you see eosinophils, right? This is what came in a recent INACD exam. When you see eosinophils in urine or eosinophils in a bladder biopsy, you think of a drug-induced interstitial nephritis. Please do remember them, right? 𝐒𝐿𝐿 is nothing but a condition where the macrophage or the immune system will not work. If the immune system does not work, macrophage keeps on accumulating. The other name of macrophage is foamy cells, right? Why it is called foamy? What made them called foamy? Fat, right? That's why you have yellow plaques. The reason for foamy macrophage accumulation is the one which gives the yellowish plaque-like condition. It's an yellow elevation, subtle elevation that makes the 𝐒𝐿𝐿, and this is even a better image of an 𝐒𝐿𝐿 body. These are calcifications seen inside the macrophage. That's classical of an 𝐒𝐿𝐿 here. Fine, perfect, great. See, like I said, it's nothing but a bacterial infection. What's the treatment for 𝐒𝐿𝐿? These are due to E. coli and Klebsiella. How do you treat? You don't do a surgery here. You have to give antibiotics. That's all. Fine. Okay. Next question. Comment on the answer. Identify the marked cell here. This is nothing but a mast cell, right? Mast cell, can anyone tell me what's a stain for mast cell? There's one stain which is very common for mast cell, which is toluidine blue. Fine. Mast cells are nothing but tissue macrophages. When you see bluish granules in a histopathological examination or in the biopsy, that's mast cell. Toluidine blue is a classical stain used for mast cell, right? Perfect, great. Okay, next. Spotter again. This is an old INACD recall question. I'll zoom this for you. A child with skin, multiple areas, initially macula, later developed as nodule, has a classical finding of, it's not a multinucleated giant cell. These are the inclusion bodies or HP bodies seen in case of an molluscum contagiosum, right? I can call it a molluscum body or an Henderson-Peterson body, right? So there is one more HP bodies. Where do you see the other HP bodies? HP bodies also the findings seen in case of an chlamydia. That HP body is Halbert-Strada-Provasak body. That's a different HP. This is a different HP. Henderson-Peterson bodies are seen in case of molluscum contagiosum, seen in the skin, right? What is a classical clinical clue you look for in molluscum contagiosum? If you see this finding in the question or in a patient, I think of molluscum. Whenever you see pearly white umbilicated nodule, that is diagnostic of molluscum. Remember this keyword, that's very, very important, right? And where do you see 𝐒𝐿𝐿? Perfect. Where do you see 𝐒𝐿𝐿? Which infection? HPV. Human papillomavirus, where you see 𝐒𝐿𝐿 cells or 𝐒𝐿𝐿. Fine. Okay, next. Identify the given instrument. What's the instrument here? It's a bone marrow biopsy needle. It's 𝐂𝐂𝐿MA. Anyone else apart from, okay, everyone was given this 𝐂𝐿MA, right? See, there are many biopsy needles used, but most likely the common thing uses Jamshedji, right? Jamshedji is the only needle which is used in real life. This is how a Jamshedji needle looks. Okay, This is the only needle which is used in reality. 𝐒𝐿MA and others have become obsolete because 𝐒𝐿MA is mostly a metal needle. These days I'm not going to sterilize them, right? I use disposable needle. Disposable JAMSG needle is used. If you want to differentiate 𝐒𝐿MA and a SALA needle, if you have an adjustable screw, that's a SALA needle. If there's no adjustable screw, that's a 𝐒𝐿MA needle, right? SALA is useful for bone marrow aspirate. That's why I have the screw and I can remove it. That's a stillet. I remove it and I put a syringe here and you can aspirate it, right? SALA, 𝐒𝐿MA and JAMSG. Mostly the biopsy needle used is JAMSG. To identify a JAMSG needle, this is what is important. JAMSG needle will have a handle. That's why it's better because I can hold this like this and you can drill the bone and take a piece of bone. But for 𝐒𝐿MA, there's nothing much to hold it. I have to hold like a pencil and drill a bone. That's a bit difficult. That's why JAMSG became more popular because of the holding thing. Fine. Okay. Yes, side screw will be there in SALA needle and 𝐒𝐿MA will not have it. Fine. Okay, perfect. Next question. The next application of whatever we read in the first half of the lecture. Tell me what's the answer. "19-year-old midline swelling moves in deglutition. Ultrasound reveals so-and-so finding extending into the staph muscles. And this is the histopathological image where I have this pink color acellular structure. That's nothing but your amyloid, right? That's nothing but an amyloid. You have amyloid deposit with cells surrounding the amyloid deposit. That's classical of an medullary carcinoma thyroid, right? Amyloid will be there in medullary carcinoma thyroid. Any thyroid with an amyloid, I want you to think of medullary carcinoma thyroid only, right? See, thyroglossal cyst will not have 2 into 2 centimeter nodule in the left lobe of thyroid and with amyloid, right? That's why it is not the answer. Thyroglossal cyst might definitely move with deglutition. That's there. But any thyroid swelling for that matter will move with deglutition. Fine. Okay. Next, spotter. Spotter. Male patient, hemoptysis, hilar mass is present, which means something related to lung. And you can see the classical finding here. That's your keratin pearl. So when you see keratin pearl and also P40 was positive, obviously has to be a squamous cell carcinoma of lung, right? Perfect, right? Just tell me what is one marker which comes to your mind in case of a lung adenocarcinoma primary. One marker for lung adenocarcinoma. There are 2 markers ideally. At least if you say one, I'll be more than happy. You have TTF1 and napsin A. It's not like which is better. Both are decent enough marker and we do both always together, right? TTF1 napsin A are marker for lung primary adenocarcinoma, right? Can anyone tell me at least one marker for small cell carcinoma of lung? Small cell lung cancer or any neuroendocrine cancer for that matter. Small cell lung cancer. Ashish, because I need to identify a capsular invasion, capsules are not visible in an FNAC which deals only with cells, right? That's why I can't have an FNAC. Fine. Okay. Synaptophysin, chromogranin, bombesin, CD457, 56, many things are there. Yes, synaptophysin is a good marker. Chromogranin is a good marker. All of them are positive for any neuroendocrine tumor, right? Perfect. Okay. Large cell carcinoma, I'm not going into it because the recent WHO calls them an undifferentiated tumor. Leave them as such. Fine. Next. It's a spotter, histopathological image of a thyroid pathology. This is the finding here. I'll zoom this for you guys. What is this? And what is this? And something is going through this. Ashish, answer to your question. This is classical capsular invasion. And I cannot see this capsular invasion in case of an FNAC. That's why I cannot do an FNAC and diagnosis follicular carcinoma of thyroid, right? Can anyone tell me what's the most common mutation seen in follicular carcinoma thyroid? Follicular carcinoma can have both translocations and mutations. One of the common mutations is RAS. To be specific, HRAS, though it's not very commonly used in diagnosis. If it comes in an exam, you should be able to answer that, right? Okay, perfect. Next. HRAS, Lydia. RAS is more than enough, right? Okay. Next. 7-year-old fever, rash, and bone pain. That's extremely classical diagnosis. Shows light depletion in the skull. And there's a biopsy here. Let's zoom this biopsy. These are nothing but eosinophils. And can you guys see that this cell kind of looks like this? Maybe to some extent here also. That's your coffee bean grooving, right? A grooved nuclei, eosinophil, diagnostic of an Langerhans cell histiocytosis. Few leading points. Can anyone tell me one IHC marker for Langerhans cell histiocytosis? One marker. There are multiple. I am sure you guys know multiple, and I'm sure you must be waiting to type Burbeck granules. One marker which I use in real life is CD1A. There is Langerhans. S100 is positive for sure, but CD1A is a bit better. CD207 is also a very good marker, but CD207 is not available in the lab, right? 1A is something which is pretty common, pretty easily available. Remember this. Whatever you said is right. Fine. Okay, perfect. Answer? "35-year-old fatigue investigation reveals hemoglobin of 5, MCH of 24. That's very unlikely, but it's fine. Okay. Leukocytes of 11,000, platelets of 5 lakhs. What's the most common diagnosis? This is a peripheral smear. Fine. Okay. First question: is it a microcytic anemia, normocytic anemia, or a macrocytic anemia? Micro, normo, macro. It's microcytic anemia, right? So I can rule this out. It's an anemia. I'm not going to think of an essential thrombocytosis in this patient at any point of time, right? So if it's a microcytic anemia, I have only two options which are microcytic, right? These two are the only options which are microcytic. Fine. Now tell me, if it is a Thal major, do you think the patient would have survived till 35 years of age without any other complication? Possible, not possible? Not possible, right? So till 35 years of age, it's not possible for a Thal major. See, Thal minor is different. Thal major is not possible, right? That's the only reason I am ruling it out. First thing. Second, whenever I see a patient with a microcytic anemia, the first thing I want you to think by default is iron deficiency anemia. I should have had history of blood transfusion or some therapy there, definitely, right? Suddenly they won't present 35-year-olds with fatigue, right? So clinically not fitting, and that's not the most common diagnosis, right? Now, some of you might have looked at this corner cell. How does it look like? How does it look like? The corner one which is circle does look like a target, right? That's why I said when we talked about target cell, though my first diagnosis is thalassemia, it can also be seen in severe case of an iron deficiency anemia. This patient is undoubtedly a severe case of IDA because 5 grams. 5 grams of hemoglobin is definitely severe case of an IDA. I don't think of a Thal major here. Still, I don't think of a Thal major here, right? Though I have a target cell, I do definitely have a microcytic cell because in lymphocyte, these cells are definitely smaller, hypochromic lymphocyte. I want you to think of an iron deficiency anemia only, right? Few takeaway points. Always match clinical presentation with the microscopy or the lab findings. Always don't go with one finding and change entirely to the diagnosis, right? I can see a random target cell, that's completely fine. I will see 50 RBCs here easily. Of that, one target cell is 0.5%. I don't care about it. It's very, very less, right? So 1 or 2%, that's all, right? So go with the predominant finding. It has to fit into clinical diagnosis. If it's not fitting into clinical diagnosis, not at all the answer, right? Samantha, yes. In a severe case of an iron deficiency anemia, you can see target cells, fine? Okay, perfect. Next question. This INICT, put a googly to your physiology lab. No one ever in this world uses this, right? That's your, what's the instrument's name? What's the instrument's name? You know the instrument's name. That's a Sally's hemoglobinometer, right? Hopefully in future we'll forget the name of the instrument also. Sally's hemoglobinometer, and the method is acid hematine method, right? So acid hematine method and the Sally's hemoglobinometer is what is seen here. I hope they don't start giving you Newbar chamber and all the old Wintrope's Westergren's tube. If it comes, I am sure you will be able to identify them. Fine. Okay, next. Diagnosis. 15-year-old boy presents with swelling in the diaphyseal lesion of the tibia. Okay. Most of you went with Ewing sarcoma, right? Let's dissect this question. See, this question is very, very interesting for an approach, right? First thing, 15-year-old boy, okay? Can I say all of this, this will not be seen in 15-year-old? Osteoclastoma or giant cell tumor is not seen in 15-year-old, right? Yes, Ashish, you are absolutely right. Everyone's answer is right. I'm just wanting you to know how to approach the question. 15-year-old boy, by default, I can remove giant cell tumor or an osteoclastoma, which happens around 30-40 years of age, right? I can remove it, right? Next, seen in the upper diaphyseal region. Where do you see osteosarcoma? Metaphysis, epiphysis or diaphysis? Osteosarcoma generally is a metaphyseal lesion, right? This generally is an epiphyseal lesion. This generally is a metaphyseal lesion, right? So I can rule this out also, fine. Because if you remember the image in the X-ray with the orthopedics and radiology, right? That's also important for me, fine. Now, these both, METs and Ewing's, both of them can happen in the diaphyseal region, right? METs and Ewing's, both neuroblastoma. Can I say neuroblastoma will also have small round blue cells? Ashish. It will have small round blue cells by default, right? It's neuroblastoma, blastemal tumor, right? So this microscopy fits into neuroblastoma, age fits into neuroblastoma, diaphyseal lesion fits into neuroblastoma, synaptophysin also fits into neuroblastoma, but MIC2. MIC2 is not positive in neuroblastoma, MIC2 is positive for an Ewing sarcoma, right? That's the reason MIC2 is much more, Ewing's will be a better answer for this question than your metastatic neuroblastomas, fine. Please be receptive with questions because everything will alter the thing. If I remove MIC2 and say synaptophysin chromogranin alone positive, rest everything negative, I will think of a metastatic neuroblastoma here, fine. Just one more additional point. For Ewing sarcoma, you have a new marker called FLI1. It's not new, it's pretty old marker only, right? FLI1 is one of the marker which is much more specific than your MYC2 or your CD99. It's very specific. And also we have NKX 2.2. Okay, NKX, right? So NKX also is a good marker, is a transcription factor, right? NKX is a transcription factor. This also is a very good marker for your Ewing sarcoma, which are currently being used, FLI1 and NKX, fine. Okay, next. Options. This is a peripheral smear. Diagnosis, spotter. You guys know the answer. I'm having too many lymphocytes here, and there's a cell here which is strikingly looking at us. It's kind of destroyed cell. That's nothing but your smut cell, right? Good number of lymphocytes, lymphocytosis, and smut cell. Your diagnosis has to be an CLL, right? For an acute lymphoblastic leukemia, you will have a blast. First question, why is this not a blast? To call it a blast, it should be 2 to 3 times size of an RBC, and there should be no granules for an OR rod for a lymphoblast. For an acute myeloid leukemia, same, blast should be there, which should be big in size, and you will have OR rods. Okay, what is the diagnostic finding? Like if you see this in an exam, I will think of a CML. What's the finding? Microscopy wise, or peripheral smear, or CBC wise. When you see, I know for a fact that the garden party appearance and the college girl appearance comes to your mind first. Neutrophilic shift to left is definitely there, but I'm more concerned about basophilia, right? Garden party never gets out of a head, right? So basophilia is much more Philadelphia chromosome, obviously. Basophilia is much more common. Basophilia is much more reliable thing compared to your garden party or your college girl appearance or the neutrophilic left shift, right? Basophilia is not seen in any other lesion apart from your CML. These are few keywords for you to pick up these conditions, fine? Okay, next. Anioxic. Okay, eosinophilia is not that common, right? Eosinophilia has multiple other options as well. That's a nutmeg liver. It's written, right? Which of the following is true about nutmeg liver? That's a question. So I'm zooming this. This is a pure case of a nutmeg liver where you have altering areas of dark area and pale area. Now the question is, which is necrotic here, dark or pale? Nutmeg is it's a Indian spice, Janvi, right? I think that's Javi or something. That's a nutmeg. Which is necrotic, pale or red? Let's see how many of you get this right answer. I want everyone here to comment. It's interesting. Which is red? Which is necrotic here, pale or red? Come on, except for Dr. Phobia, no one else has commented. Pale is necrotic, carpal tunnel. Others. Thank you, Prakash. Others. Which is necrotic? Pale or red? See, you have 50% of right answer. Pale, pale, pale. Amazing. I'll show you the options very soon. Okay, perfect. Here in this nutmeg liver, especially, you will have centrilobular hemorrhagic necrosis. Okay, because like a red infarct, right? This is hemorrhagic necrosis. So now tell me which is necrotic, pale or red? Red is necrotic in this condition. Generally, I'll think of a pale area to be infarcted, but this is nothing but an extravasation hemorrhage induced necrosis. So red area here is necrotic, or the dark area is necrotic, and the pale area here is clear, which is normal, right? Now let's go to the option. Now tell me which will be the right option. Central dark area, central hepatocytes is necrotic, and the pale area, periportal hepatocytes, is viable, right? This is the right answer here. Viable area is paler, not exactly white, yellowish color because of the normal liver's color, and they are periportal. And the centrilobular, surrounding the lobules, that's where the backflow comes, which results in the hemorrhagic necrosis, right? In which condition do you see nutmeg liver? Can anyone add on to that? In which condition do you see nutmeg liver? Nutmeg liver is seen in right heart failure, right? So when there's a right heart failure, there's a back pressure in IVC. From the IVC, there's a back pressure to the hepatic vein. From the hepatic vein, there's a back pressure going into the central vein. So the back pressure goes, so surrounding the central vein, all of them will be destroyed. That's hemorrhagic necrosis, darker area, and far away from the central vein, that's periportal hepatocytes, they are viable, right? Yes, chronic venous condition, which is secondary to heart failure, right? Carpal tunnel, fine. Okay. Hadi, I don't have the picture here of the microscope. I'll show you sometimes later. Okay. Diagnosis, this is Potter. Everyone will bounce onto the answer. Diagnosis, that's a classical one, right? I don't think so yet they have asked this in an exam. No one will make a mistake if it's asked. The tennis racket chip appearance, Berber granules, spotter, diagnosis of an LCH, right? This is seen in Langerhans cells. If the option does not have LCH and just they have Langerhans cells or any histiocytic lesion, it will be positive, right? Okay, perfect. Spotter again. What's the right answer? What is asked? Okay, great, Ashish. Sorry. Hodgkin cell, RSL, Hodgkin's lymphoma, RSL, and associated with an EBV infection, right? It's a classical outside appearance. This is a classical RSL. Okay. So now tell me, what is the immunohistochemistry for a classical RSL? For every classical Hodgkin's lymphoma, be it nodular sclerosis, mixed cellularity, lymphocyte rich and depleted. What's IHC? Your CD 15, CD 30, right? And one more IHC I'm going to add, but that's one more thing is important in that IHC. PAX5. PAX5 is strongly positive or weakly positive in Hodgkin's lymphoma, classical RSL. PAX5 is strong or weak? Just comment on that. For a classical RSL or a classical Hodgkin's lymphoma, PAX5 is strong or weak? It has to be weak. See, that's the most important thing here. If it is strongly positive, it is not classical Hodgkin's lymphoma. Please do remember, right? If PAX5 is strongly positive, I will think of a classical B cell tumor, which in Hodgkin's is NLPHL. Okay, it should be weak. Only when it's weak, you think of a classical RSL. Otherwise, you think of an NLPHL, right? Perfect. Yeah, even in CLL or any B cell neoplasm, it will be strongly positive, right? Okay, perfect. Spotter again. What comes to your mind? It's spot, right? It's your ferruginous body or an asbestos body, right? That's it. Okay. So now here, what is the disease called as? Cotton fibers exposure. What's the occupational lung disease called as? Few pointers regarding occupational lung disease. It's your bacosis or byssinosis. Cotton fibers. It is byssinosis, right? Bacosis is seen secondary due to sugarcane dust. Sugarcane is bacosis. Byssinosis is cotton fibers, right? Doctophobia, bacosis is sugarcane. Bizzinosis, cotton fibers, right? Silica, what is a classical clue on microscopy for silica? See, because all the occupational lung diseases are fibrosing lung disorders, fine? If you see birefringent particle, that is silica. Coal is not birefringent. Your asbestos body is not birefringent. Silica is birefringent, and obviously you'll have a huge fibrotic nodule. That's classical for silica. Coal. What's a classical microscopic finding for coal? What color you will see in coal? Coal you will see black. If you see black color on microscopy, on gross, obviously the first diagnosis is undoubtedly coal, fine. And you see a brown particle, you think of an asbestos body, fine. Okay, perfect, amazing. Okay, next, spotter. This time INICET had this, right? After a long time they asked this, hopefully it repeats in NEET exam as well. What type of crystals are they? That's an, is it envelope shaped crystal or a coffin lid shaped crystal? This is an envelope shaped crystal, right? You see them in calcium oxalate, right? This is like an envelope shaped crystals. You see them in calcium oxalate stones, right? See, these are the only 4 crystals which is practically important. Of that, if I am a pathologist, the only crystal I need to know is cystine stones, because cystine stones are very, very hard. So if it's very hard, I can't do extracorporeal shockwave lithotripsy. So if I see cystine stones on microscopy, the first management is your surgical management. Your extracorporeal shockwave lithotripsy will not work in case of cystine calculate, right? It's the hardest and it's hexagonal shape, right? Calcium oxalate has the envelope shaped crystals, calcium phosphate like a thorn, and cholesterol crystals. You can have cystine crystals which are hexagonal shaped. Okay, what is this shape? Struvite stones. I can't do ESW, fine. Struvite stones are your coffin lid shape, right? And uric acid, that's not the exact one. Uric acid has weird shape of crystal. Based on the axis what I'm looking at, uric acid has a rhomboid shaped crystal. That's how uric acid crystals look like. Okay, perfect. Which of these crystals are more common in alkaline urine and seen secondary to protease infection? Alkaline and secondary to protease infection. Whatever comes to your mind. It's generally your struvite or your triple phosphate crystals are more common in alkaline urine and seen in protease infection, right? Perfect. Next, the spotter. Diagnosis. You have a central asymmetrical septal hypertrophy and a very thin sickle-like ventricle. What's the diagnosis? The entire question is based on the diagnosis and what's the symptom in this patient. It's a classical patient with HOCM, right? Now, what will be the perfect thing for HOCM? HOCM will definitely have sudden cardiac death, but not due to valvular, not due to arrhythmia, not due to obstruction, is due to hypertrophy of heart. HOCM will, the classical symptom is athlete falling down or collapsing on the field while playing. That's a classical symptom for HOCM, right? Perfect. HOCM, is it inherited or acquired? Inherited, acquired. HOCM is undoubtedly 100% inherited, right? HOCM is not acquired. HOCM is 100% inherited. Fine. Dilated cardiomyopathy can be acquired, but HOCM is always inherited. Fine. Okay. Spotter. I'm sure by this time you must have been an expert of all these vacutainers. You guys know more vacutainers than what is there in the laboratory. You have the golden yellow. We don't see gold color or tan shaped vacutainer in lab. Lab has this, which is a clot activator. Lab does have EDTA, which is purple or lavender. Lab does have trisodium citrate, which is blue, right? Sodium fluoride, what color? What color will have sodium fluoride? The enolase sodium fluoride will be your gray color vacutainer, right? And heparin is going to be a green color vacutainer, right? Okay. Heparin is green color and sodium fluoride is a gray color as an additive seen in gray color vacutainers. Fine. Perfect. Amazing. Like I said, you guys know more vacutainers, more than what you have to know. That's the biggest problem of this generation. Information excess. Okay. Diagnosis, spotter. Patient with an abdomen pain and the image as shown here. Okay, and hematuria, purpura all over the legs. That's a classical symptom of an 𝐒𝐻 colon purpura, right? Okay. IgA nephropathy can be a subtype of 𝐒𝐻 colon purpura, because what is the finding I see in case of an kidney in patients HSP is IgA nephropathy by default, right? But I can't call this an IgA vasculitis because I have this, this, and this. Since everything is there, I go with 𝐒𝐻 colon purpura and not an IgA nephropathy alone. That's a separate entity, right? Just one leading question before we go to the next one. I'm not ignoring your drug of choice. I'm seeing them. Did you ask some question? Okay, HSP full form is 𝐒𝐻 colon purpura. Okay, what is the type of purpura you see in HSP? Palpable, non-palpable? If you have put any questions I have not repeated, just can you copy paste it once again? You'll see palpable purpuras, right? For any vasculitis, the purpura is going to be palpable. HSP is definitely a vasculitis. It's a palpable purpura. Non-palpable purpuras are seen in your platelet-related disorders, right? Okay. Spotter, the classical finding. You have a nodule, nodular glomerulonephritis, your KW lesion, right? Okay. It's a classical finding case on diabetic nephropathy. Actually, Armani-Epstein change is also a finding seen in diabetic nephropathy. Can anyone tell me which part of the kidney you will see Armani-Epstein lesion, or which part of the nephron you will see Armani-Epstein lesion? Armani-Epstein lesions are seen in your proximal convoluted tubule. These are nothing but glycogen deposit in the proximal convoluted tubule, right? Not very specific. KW lesion is definitely more specific than your Armani-Epstein change or your Armani-Epstein lesion, right? Perfect. Okay. FSGS and MPGN are different findings. I'm sure you will be able to pick them up. Spotter. Yes, Nayak, you're right. Apple green. Who can forget apple green, right? Everyone will remember apple green by reference. It's undoubtedly amyloid, right? So can anyone tell me what stain is used here? The stain used here is by default your Congo red. Okay. Can anyone tell me one stain for lipid? Just one stain for lipid. Lipid stain, Sudan black B or an oil red O. Just one more additional question. What is the fixative for us to do a lipid stain? For me to do a lipid stain, you need a fixative. What's a fixative used for lipid stain? Lipid stain will not be picked up on formalin fixative. What's a fixative? That's your. It should be a frozen section. Only in a frozen section I can see them. I cannot see them in a formalin fixative. Neutral buffered formalin will kind of remove the lipid. So I can't use an SBB or an oil red O. It should be frozen section, right? It should always be frozen. Okay. Collagen stain is your Mason's trichrome. That's a stain for collagen. And in Mason's trichrome, blue color is for the collagen. Okay. Calcium stain. You know the stain for calcium, right? It's 1-CoSA and your alizarin red. But I am more than happy with 1-CoSA. Right? Okay. Because it will be washed away. Samantha. 1-CoSA and alizarin red. These are the calcium stain. Rhodamine is for copper, right? Okay. Fine. Great. Okay. Spotter again. Let's see how many of you tell the right answer. Okay, amazing. Why not A? B is a very simple answer here, right? It's a hypersegmented neutrophil. You think of a vitamin B12 deficiency. Why not folate deficiency? Tell me that. Why not folate? Great, Himani. Neurological deficits are seen only in case of a B12 deficiency, right? So please be very careful with the history, because hypersegmented neutrophil can be seen both in folate deficiency as well as in B12 deficiency. Since there's neurological deficit, I lean towards this, right? Let's assume there's a patient with a history of no consumption of fruits or vegetables, no fruits in the diet, most leaning towards no fruits in the diet. I think of an folate deficiency, right? Because vegan diet is different. Paraffin is a section, Himani. your fixative is different, paraffin is different. Fine. Fixative is formalin, paraffin is where I just use them to cut them. That's all. Okay. So there's no fruit in the diet. I think of this. Fine. I will call it a dimorphic anemia when you have both iron deficiency anemia as well as your macrocytic anemia, where you have microcytes and bigger things. Okay. Perfect. Okay. Next. History is more than enough. The stem of the question is more than enough than this image. Though this image is what is going to attract you a lot. That's your MOT cell, right? A plasma cell with lots of vacuoles there. Obviously diagnosed multiple myeloma. 65-year-old, low back pain. Electrophoresis demonstrates an increased level of IgG. There's nothing but your M spike, right? Creatinine levels elevated. Skull shows multiple punch out lesion. Everything here is suggestive of it. It's a multiple myeloma. Shubham, Russell body is a single inclusion. MOT cell is multiple grape-like. MOT means like a berry, like a mulberry or a strawberry. It will have multiple grape-like inclusion. That's a MOT cell. You have single inclusion, you call it a Russell body. Fine. Okay, great. Next. Your answer. Whatever comes to mind first. Sure, Ashish. That's 35-year-old person, right knee joint, around the knee joint, which means epiphyseal lesion, soap bubble appearance, and then you have multiple giant cells. That's your osteoclastoma or a giant cell tumor, right? Only one leading question here. In an osteoclastoma or a giant cell tumor, which is the neoplastic cell? The giant cells or the stromal cells? Which is neoplastic cell here? The neoplastic cell is always the mononuclear stromal cell. Giant cell here are not the neoplastic cell. Giant cells are the reactive cells which comes here. That's why osteoclastoma is ideally a misnomer. Fine. Ashish, MGUS will not have your clinical symptom or the CRAP criteria. MGUS might not have the M spike. MGUS is like a very early onset of multiple myeloma. The only difference between Waldenstrom's macroglobulinemia and a multiple myeloma is Waldenstrom is only IgM. Multiple myeloma can be IgM, IgG or IgA, right? Second, Waldenstrom is a lymphoma. So will that be lymphadenopathy? There will be. If you have the same history, same finding, but there's a history of lymphadenopathy and there is IgM, I think of a Waldenstrom. Multiple myeloma is a problem of the bone marrow, will not have lymphadenopathy. If you have lymphadenopathy, hyperviscosity syndromes, IgM, you think of a Waldenstrom's macroglobulinemia. Fine. Perfect. Okay. Spotter. Something which you might not see, but everyone knows this. SLE patient vegetation has to be your Lippmann-Sachs endocarditis, right? And I'm sure you must have seen the image what I'm going to show again and again and again multiple times. There's a beautiful description of all the vegetations from Robbins. Rheumatic heart disease, they are verrucae and they are sterile. This is the only place I feel you might miss it due to just because you are urgent. That's all. It's just in a hurry, right? Lydia, I'll ask Santosh to intervene on that because I don't see SLE patients till they die. My thing restricts with the microscopy. I don't think so. Renal diseases will cause death in SLE. Practically speaking, because I can do renal transplant or a hemodialysis. It will definitely cause renal failure. Death is a bit unlikely. Fine. Still, I'll ask you to get an opinion once from Santosh. Fine. Okay. Infective endocarditis is the only vegetation which can destroy the valve and they are huge and bulky, right? NBT is also on the sides of the valve, but they are a little bit bigger. Okay. And when you see on both sides, that's your Lippmann-Sachs endocarditis, which is SLE. Rheumatic fever is the acute rheumatic fever, the term given. Rheumatic heart disease is generally meant for the chronic disorder which happens in the heart and the cardiac valves. Fine, Samantha. Okay. Spotter. Diagnosis. Actually, shouldn't have been spotter, but I did include because I had put this in my Instagram poll recently. Fine. You have a rosette here and you have a pink structure in the center and then you have a central lumen. Rosette, pink structure, central lumen. It's a spotter. That's a classical Flexner Winter-Steiner rosette seen in case of an retinoblastomas, right? Okay. So there are 4 different types of rosettes, ideally 3. Fourth is your perivascular pseudorosette. I'll show all 4 of them. Fine. So when you see a rosette with no lumen, only pink color in the center, right? No lumen, only pink color in the center, you call it an Homerite rosette. Where you guys see Homerite rosette? Can you guys comment? Homerite rosette is classically seen in perfect neuroblastomas and medulloblastoma. This is a pseudo rosette, right? Because it's completely fine. Okay. Next here, if you look at this, okay. Thank you, Batal. Okay. So if you look at this, you have a central lumen, then you have a thin rim of pink colored tissue here, and then surrounding that you have your tumor cells. That's your Flexner-Winter-Steiner rosette. Flexner-Winter-Steiner rosette is undoubtedly a true rosette, and it's seen in classical case of a retinoblastoma, right? Now if you look at this, you have only a lumen, nothing else, only central lumen, and then you have cells surrounding them. This is classical true rosettes seen in case of an ependymomas. Fine. As a finding seen in ependymoma, only lumen and cells surrounding that. You see a vessel, red color is obviously vessel. Surrounding the vessel, you have all the tumor cells. This is a perivascular pseudorosette. A perivascular pseudorosette is seen in case of an Ewing sarcoma. You can see them in neuroblastomas. You can see them in medulloblastomas. It's very, very non-specific finding, right? There are 4 rosettes. If you see a central lumen or an empty space, that's a true rosette. These 2 are true rosette. Flexner-Winter-Steiner and ependymal rosettes are true. Homerite and your perivascular pseudorosettes are true pseudorosettes. Fine. Okay, let's go back. Clear, Shubham? So you have a central lumen, then you have a pink surrounding, then you have the tumor cells. So this is a Flexner-Winter-Steiner rosettes, which is classically seen in case of a retinoblastoma. Clear? Fine. Perfect. Let's go to the next one. Spotter. What is the name cell here? The cell is a target cell, right? Sorry, it's a teardrop cell. Fine. Obviously, we do have target cells also here, but whatever is being marked, it's a teardrop cell. Teardrop cell is classically seen in, or a dacrocell is classically seen in myelofibrosis. Whenever we have a myelofibrosis, you see them, right? It's a classical finding seen in myelofibrosis. Unlikely for a patient with see, teardrop classical finding is seen in myelofibrosis. IDA is very non-specific finding. It's not a specific finding IDA. Pencil-shaped RBCs are more specific for an IDA, not a teardrop RBCs. Fine. Okay. Spotter. I hope they'll ask pathology image-based questions like this, right? So that everyone can answer. Child, jaw swelling, that's more than enough for us. And cervical node has a classical starry sky appearance. That's diagnostic of a, where is it? Burkitt's lymphoma, right? Can anyone tell me what is a Ki-67 in case of Burkitt's lymphoma? Low, high, what's a Ki-67? Ki-67 is undoubtedly high, which is 100%, right? Ki is 100%. This is the only tumor where Ki-67 can be 100%. That makes them extremely, extremely sensitive to chemotherapy, right? Okay. Ashish, MDS is not actually required for an undergraduate. MDS is myelodysplastic syndrome. It's like normal dysplasia. This myelodysplastic syndrome can progress to a leukemia. So when you have a blast percentage of 5 to 19, I call it an MDS. 0 to 5 may be normal. 5 to 19%, I call it an MDS. And more than 20, I call it an acute leukemia. So MDS is in between, where I can have dysplasia in the RBC, WBC, and the platelet lineages. Fine. Okay. Spotter. It's a karyotyping. I'm just zooming the karyotyping so that you can find the right answer. Diagnosis. Whenever you see a karyotyping, I just want you to count, and everything should have only 2. If something has 3 or 1, it's abnormal. Now, my 21st chromosome has 3 chromosomes here. So undoubtedly it's a Down's baby. Yeah, it's a Down syndrome kid, and it's a Down's. So just few questions to follow up with Downs before you sign off. Downs is inherited or acquired? Downs is inherited or acquired? It's not better, right? Which one, Samantha? I missed your question. Downs is... Okay, that's surprising. Okay, let me rephrase the question. Fine. Down syndrome. What's the risk factor for Down syndrome? Can I say it's increased maternal age? Yes. Increased maternal age is the risk factor for Down syndrome. Undoubtedly, yes. So now tell me, it's inherited or acquired? Down's an acquired condition, right? It's a genetic disease. Please don't confuse genetic disease with an inherited disease, right? Inheritation means it should come from the parents to the offsprings. That's what is inherited, right? So Down's is an acquired genetic disease, fine? Okay, so please don't confuse that. Down's an acquired, it's definitely a genetic disease. Okay, it's not inherited, Down's is acquired. Any patient more than 35 years of age, they have a risk of Down syndrome, that's all. Maternal meiotic non-dissection happens at advanced maternal age, that's it, fine? And that's why the most common cause of your intellectual disability or mental retardation, the most common cause is Downs, and I'm sure you must have heard this also. What's the most common inherited cause? Most common inherited cause of mental retardation or intellectual disability? It is Fragile X syndrome, because Fragile X is inherited. Downs is not inherited. Fine. Downs is an acquired disease. It's an acquired genetic disorder. Fine. Perfect. Great. So that's all for today. I'll upload the PDF. I'll give the PDF in next few minutes. I'll give it to the tech team. They'll upload in the Telegram channel. I think the Telegram channel link also will be there down. And see you. All the very best for the upcoming FMGE exam if you're writing it. And I hope and I wish and I pray NB will give the final date for the NEET PG soon. And use the time valuably. Enjoy, read as well. Fine. See you. Thank you so much. Samantha, the karyotypic image has 321st chromosomes. When you have 321st chromosomes, it is definitely that. Wish you to your drug of choice. All the very best. Do very well. Okay. Bye-bye.